To successfully decompress a patient's stomach or begin enteral feeding, we need to get a nasogastric tube safely in place and securely anchored. Step 1 is patient positioning. Sit the patient upright in a High Fowler's position, angled at a minimum of 45 degrees, with their shoulders well supported. Because the patient won't be able to speak comfortably during the procedure, establish a clear hand signal right now. This gives them a way to tell you to stop if they experience too much discomfort. Next, gather your supplies at the bedside. You will need a 14 to 16 French gauge NG tube, water-soluble lubricant, an enteral syringe, pH litmus paper, hypoallergenic tape, and a cup of water with a straw. Perform thorough hand hygiene and put on a pair of standard PPE gloves to maintain aseptic technique throughout the process. Aseptic technique refers to the clinical practices used to prevent contamination from pathogens. By organizing your supplies beforehand, communicating clearly with the patient, and ensuring the correct physical posture, you turn a highly uncomfortable experience into a structured, cooperative process. Start by placing a towel or a linen saver pad across the patient's chest to catch any potential spills or emesis. Emesis is the medical term for vomiting. This diagram illustrates the path we use to measure the correct insertion depth. First, extend the tube from the tip of the patient's nose to their earlobe. From the earlobe, continue measuring down to the xiphoid process at the base of the sternum. Note this exact target length, which typically lands between 50 and 55 centimeters for an adult, and mark it directly on the tubing with a small piece of tape. To make the tubing more pliable, tightly wind the first 4 to 6 inches around your index finger to create a gentle, downward-pointing curve. Then, generously coat the tip with a water-soluble lubricant, preferably one containing lignocaine. This measurement prevents the tube from stopping short in the esophagus or coiling in the throat. You now have the exact length required to bridge the nasal passage and reach the stomach. Use a pen light to inspect the patient's nasal passages and select the nostril that is the most clear and patent. With the patient's head against the pillow, slowly insert the lubricated tip into the chosen nostril. Aim the gentle curve downward, guiding it along the floor of the nasal passage. Stop the insertion the moment you feel the tip reach just above the oropharynx, which is the back of the throat. Ask the patient to tilt their head forward, chin to chest. This movement compresses the tracheal opening and widens the pathway into the esophagus. Have the patient take small sips of water. This triggers a swallowing wave that safely pulls the tube past the airway. Fall into a steady rhythm with the patient. Advance the tube smoothly by 1 to 2 inches with every single swallow they take. Watch closely for severe coughing, intense gagging, or gasping for air. If the patient begins to cough forcefully, pause immediately. Withdraw the tube slightly and let them catch their breath, as coughing indicates the tube may have accidentally entered the larynx. By timing your movements to the patient's sips, you aren't forcing the tube down. Their biological swallowing reflex acts as the mechanical engine, safely guiding the tube into the esophagus. Even with a smooth insertion, you must never introduce feeding solutions or medications until stomach placement is definitively confirmed. Attach your enteral syringe to the distal end of the tube and gently pull back on the plunger to aspirate a sample of the stomach contents. Healthy gastric fluid typically appears cloudy and greenish, though it can also be off-white or tan. To prove the fluid is acidic, expel drops onto litmus paper. This chart represents the pH scale. Look for a color change indicating a pH below 5. This confirms the tube is resting safely in the stomach's acidic environment. If you pull back on the syringe and get no fluid, roll the patient onto their left side. Wait a few moments and try aspirating again. A pH reading below 5 is the only definitive bedside proof of correct placement. If you cannot obtain an aspirate to test, you must order an X-ray to confirm the location before using the tube, preventing the severe risk of pulmonary aspiration. Once placement is verified, secure the tube to the patient's face. Cut a piece of hypoallergenic tape so it splits at the bottom. Place the wide, uncut top across the bridge of the nose, and wrap the 2 split ends tightly in a spiral around the tubing itself. Fasten the distal end of the tube to the patient's gown using a safety pin or an additional piece of tape to prevent accidental pulling. Open the clinical chart and record the date, time, and the patient's consent. Note the confirmed pH level and the exact insertion distance marked in centimeters at the nostril. Applying that final piece of tape and signing your notes officially completes the procedure. The NG tube is now a cleared, active medical tool, ready for use. Before leaving the bedside, ensure the head of the bed remains elevated at a minimum of 30 degrees. This angle uses gravity to prevent gastric reflux. Check on the patient's comfort. Let them know that feeling like something is stuck in the back of their throat is a normal physical response, and that sensation will rapidly fade over the next few hours. By executing an accurate anatomical measurement, coordinating the insertion with the patient's natural swallowing reflex, and proving placement through rigorous pH testing, you guarantee both patient safety and clinical efficacy.